Hello everyone, I'm Dr. Kalin, a general and bariatric surgeon, and in this video I will demonstrate the modifications that occur in our digestive organs after gastric bypass surgery. The first gastric bypass surgery for weight loss was initially performed in 1967 by surgeon Edward E. Mason at the University of Iowa. He offered the surgery to some obese patients after noticing that people who underwent partial stomach and intestine removal for ulcer or for cancer experienced considerable weight loss. Over several decades, the gastric bypass has been modified into its current form using a Roux and Y limb of intestine. Gastric bypass surgery creates two major modifications in the anatomy of our digestive system in an attempt to provide weight loss by two mechanisms: restriction and malabsorption. In the first step, the stomach is divided into an upper portion called the pouch and the lower portion called the remnant. The pouch is about the size of a golf ball and can only hold 1 ounce of food. This modification of the stomach anatomy represents the restriction part of the gastric bypass surgery. This could potentially contribute to weight loss by limiting the amount of food that you can eat with each meal. In other words, after the surgery, you should only be able to eat a small portion of food with each of your meals. In the second step, the intestines are rerouted in such a way that the nutrients from the food that we eat have less contact with the intestines and less calories get absorbed into the bloodstream. This step is achieved by dividing the intestines as shown here and reattaching the divided ends in order to connect the gastric pouch and the intestine back together in a Y shape. That's where the name Roux and Y comes from. Dr. César Roux, a surgeon from Switzerland, had also contributed to the development of this procedure, hence his name is used here for his acknowledgement. This new arrangement of the intestine will create a new structure out of our intestine with three parts: the alimentary limb that transports the food from the gastric pouch to the common channel, the biliopancreatic limb that brings the bile and pancreatic secretions along with the secretions from the gastric remnant down to the common channel, and the common channel where the food comes in contact with the digestive juices and where the nutrients are being absorbed into the bloodstream. In this new setup, the food initially travels from the mouth to the esophagus, into the small gastric pouch, and then directly into the small intestine. This way, the rest of the stomach and the part of the small bowel is bypassed and the food does not come in contact with this part of the intestine. Hence, less nutrients are available for absorption. This modification of the intestine anatomy represents the malabsorption component of the gastric bypass surgery. This newly created malabsorption could potentially induce weight loss as well, along with the restriction mechanism mentioned earlier. Thank you.